got a packed room here, just anxious to see this wonderful new valve. And with me, Becky Hahn and Molly Zerlip are on the panel. So the podium is yours.
Thank you. I'm honored to present in front of Becky and Molly, but most especially my mentor and my friend for many years, Dr. William O'Neill. Thank you, Bill. I'm joined by my partner, my TAVR partner. I think we spend more time together than we do at home with our structural program. Dr. Bob Riley, who's taught us just so much about valve anatomy and valve pathology. And also, I'd like to introduce for the first time our new young partner from William Beaumont Hospital. He did his fellowship there, and he's just joined us, Dr. Pratik Dalal. Bill, we're going to get right into this so that we have time for discussion. Could we have our slides? Pratik, would you mind taking us through the case?
Sure. Good afternoon. We have an 86-year-old female here, past medical history of atrial fibrillation. She's on chronic warfarin therapy. She's got a CHA2DS2-VASc score of 3. She also has hypertension, dyslipidemia, OSA, COPD, and her medications are listed below. Next slide. She presented to the clinic with progressive symptoms of dyspnea and fatigue. At that time, she was diagnosed with severe aortic stenosis with a peak velocity of 4.3 meters per second, mean gradient of 40 with an aortic valve area of 0.7 centimeters squared. She had preserved ejection fraction, 65%, with an STS score of 3.8%. Next slide. She underwent diagnostic coronary angiography, which showed no obstructive CAD, and she was evaluated by the heart team and deemed appropriate for TAVR based upon her comorbidities.
Okay, I'd like to introduce now Dr. Robert Burke, our imaging specialist. Could we go back to the slide? Next slide, please. Bob, you vetted this case. You found that the area was 444. Talk to us about what your thoughts were on this one.
So in this case, we went through the 3-Mencio for her valve sizing on CT, and she fits right in the middle of the 25 valve as far as area and perimeter is concerned. Coronary heights are great. There's no problem from that standpoint. So really she looked like an excellent candidate for a 25 valve.
Go next slide, please.
And again, we also looked at the peripheral vasculature, and her iliacs are wonderful. They have some calcification, but no annular calcification. Nothing to worry about as far as getting in trouble there. And they were all in excess of 7 millimeters.
So Bob, we need to, right now we're doing all of these with the 20 French sheath. So your minimal size for the lower extremity vessels is what?
We try to keep it above or around 7 millimeters. That's the best thing that we can do. Sometimes you can go a tiny bit below that, but that's clearly trying to be on the safe side with 7 millimeters.
And soon enough, I think we'll be deploying the Lotus Edge through a 15 French eye sheath, and that will probably grow the number of patients that we can do just on vascular access alone. Next slide.
So again, looking at the aortic valve, you can see that there's leaflet calcification, not a ton of annular calcification in this case, but definitely enough annular, or rather leaflet calcification that should allow for good purchase and securing the device quite nicely.
So go to the next slide. So our therapeutic strategy was to implant a 25 millimeter Lotus Edge through the right femoral access. Go next. I know they talked about the anatomy of this device. One of the things I wanted to touch on is the locking mechanism, which you heard of, the buckles and the posts. And you can see that the buckles and posts, there's a black marker on both of those in this animation. But if you go to the next picture, I put the buckles and post and the movement and the locking mechanism and the animation to the left in a real case that we did, so you can see in a real valve what that locking mechanism looks like. So to the case, Bill, you talked about the retrievability and the ability to resheath, that you don't go through a hypotensive phase, and that the paravalvular leak data with this looks great. You and I have chatted recently about when you find infraannular calcium, the potential benefits of this device. Why don't we start working, and maybe you and the panel take us through your thoughts on that.
Yeah, Dave, before, just one quick question. The valve is approved for high-risk cases in the United States, and the patient had an STS of 2.7, I think. Is this a protocol case, or how did you kind of work this out with compliance?
Yeah, there were some orthopedic issues on this patient. I probably should have talked about that. We had orthopedic issues that we thought took this above that made this eligible outside just an STS score. some significant orthopedic issues. And so when we chatted about this, we thought she wouldn't be a good rehab candidate for surgery.
Great, great. So I think that Dave is just getting ready to put he's got the Safari wire in there. Molly, you want to comment a little bit about the wire, why use the Safari, and what's the strategy with the wire? Because it's different than with the core valve.
Yeah, so for these pre-shaped wires,
Give me a little more volume in my
in
ear,
general,
please.
they're probably safer than not having a pre-shaped wire. And for this valve, again, the capsule sits very close to the apex of
Ready
the
to
left
BAV?
ventricle, so you really want the capsule to be kind of wrapped up on the circular part of the Safari wire. For this valve, you don't really have to do any wire manipulation to get this valve to sit where you want to sit. It sort of sits where it's supposed to.
Right, Molly. We kind of say that the wire doesn't really do much other than act as a rail. You know, push and pull the wire to move your valve.
Okay, we're going to do a BAV here. Are we ready? A little ECTP. Okay. Dr. Schwartzstein? Yes, sir. Rapid pace, bring the lungs down. So we do a BAV on most of ours. Go ahead, Bob. And this is an 18 true balloon, and down. And we didn't see a lot of leaflet calcium. You can bring the lungs up and stop pacing quickly, please. We didn't see a lot of annular calcium. There was leaflet calcium, so you kind of saw the balloon move to and fro in and out of the ventricle and aorta. Bill, what percentage of the cases are you doing BAV on?
Dave, I was going to just ask that. I mean, it sounds like when we start a program, when we start doing these Lotus cases, it probably would be worthwhile to do a valvuloplasty. I mean, I don't really see a downside. If you get a ton of PV leak, you can just go ahead and quickly put the valve in, and it seems like it makes the deployment of the device a little bit more routine. You don't have to do as much repositioning if you got the valve already partially open.
Right. If you could zoom in on, we're going to do a little zoom here so you can see that when we go in through a right femoral access, there's an S shape to the device on the table. And when we go in through a left-sided access, there's a two shape or a question mark shape to the device. That's just the orientation that works best. Now, Bob, you want to talk about when I hand this off to you, what you're looking for on the nose cone?
Sure.
It might be hard. Oh, maybe you can see that. Zoom right in on that nose cone. Bob, you want to discuss that? Zoom right in.
So there's a lot of energy in this valve as it's loaded and as it's pushed in because of the S-shaped curve. So what we want to do is make sure it's not oversheathed to beginning or end. And the tip of this nose cone and the pusher, so to speak, you want to have about a fingernail breadth after you get it loaded on the wire. We check it on the back table and then check it again.
We don't have the wire yet? Okay.
So, and to answer Dr. O'Neill's question, we BAV 100% of our Lotus valves.
Yeah, I don't really see a reason not to. I mean, I think it's just you don't want to regret it. It seems like, especially in really heavily calcified valves, it would be worthwhile doing.
Can I have a little more ear volume?
BAV regret is something that Dr. Ryzik is always afraid of. So as you push this valve in, there's a lot of energy and the wire manipulation. You have to pull back a lot because of the stiffness of the catheter at first.
Okay,
so it's definitely a two-person talk to each other kind of procedure.
Open us up full. There you go. Bob, describe what you're doing now with that dot, that center marker there.
So first of all, you have to have the catheter super lubricated to push it, to advance it. And in the middle of the valve here, there's a mid marker that will correspond to the top of the adaptive seal. And as we advance the arch, we want that to be on the lateral aspect or greater curve. And I have to advance and twist at the same time so you can see the marker on the outside.
Well done. Very well done, Bob. That's great.
And we're going to pull some tension on the wire as we cross steadily. No different than a core valve in feel here. It's not any different. And then we're going to stop here and go to our implant angle.
Implant angle and mag up. Yes?
Just curious, are you using Sentinel on what proportion of your cases?
Oh, boy. How much time do you have? We're not using Sentinel very often at all. How about you,
Okay.
Bill?
All right.
Okay, try to quiet the wire a little bit.
Yeah, that's better, a little better. You wanna, there we go. All right, I'm just trying to quiet things down in terms of the ectopy.
She had a lot of ectopy while we're sitting here waiting.
There we go, that's better. Okay, so if you look at the handle here, what you're going to see during the deployment, and I love your depth, Bob, what you're going to see during the deployment is, come on up close on the handle, come on up closer, there you go, right on there. So I'm going to do a counterclockwise rotation, and Bob and I are just going to communicate back and forth, and we take turns, who's the captain and who's the first mate. I'm going to let Bob be the captain on this one, so you talk me through when you want me to do things. And I think the most important role, this is just unfurling, Bob's positioning, and he does a superb job at this, is really, really key. Watch the posts and in relationship to the pigtail and the depth, and you kind of get a feel for how we do that. Bob, you want to talk through it while?
So we're going to start unraveling, and it's going to dive just like a core valve will. And when they talk about letting the valve get about 6 millimeters below the annulus to start, and then it will retract from the ventricle up to about 3, our goal. Another thing to keep an eye on is actually those tuning forks. We want to keep them centered on our pigtail. So a combination of those two things is what we're going to shoot for.
Now we're starting to see it unfurl a little bit.
And this valve, we don't expect an early grasp, not a lot of calcium here. So
I like your depth, Bob.
I do. Pull back, Bob. There you go. So as he's doing this, I'm pulling back. Pace a little faster, Schwartzstein. We're pacing at 110 right now.
So what I'm looking for is the symmetry of the braid density as it's coming out. So far, it doesn't look like a banana-shaped deployment. Everything looks really good in terms of the density of our braid, et cetera. So I kind of like what we're doing here, getting a little bit more ectopy. I think that's just our wire.
And by the way, the valve has been functional since we were about 20, not attached to anything. So the valve was functional immediately, but what just happened there is we dove deep, even though we should have been starting to grasp. Don't like where it is, so you can see David's closing up a little bit, just until we release from the anatomy and can reposition back a little higher. So right about there, I think.
Okay, so that's a partial resheath, and you get, that's the sort of the mulligan factor on this. You get a couple of partial, you get more than a couple of partial resheaths. You get a number of partial resheaths.
Again, we looked a little deep on echo initially there. We still have a little bit of depth on echo.
Okay.
Pace faster, please.
You like where we are, Bob?
I do.
Because now we're starting to make contact. Bill, you think we're making contact there?
Yeah, yeah. I thought that it
We'll
was
go
a little deep
faster
on the
at this
left. It looks much better now.
And our braid density looks spectacular. Now, what we're going to do here is slow down the deployment. It look pretty good braid symmetry. Now, what I'd like you to do is, Bob, I'm going to need you back. Bob Burke, I'm going to need you back. There you go. So come a little bit caudal. It keeps coming. Let's see if we can put those all on the same plane. Now go a little bit LAO. Now come this way. Come this way. Keep coming. Keep coming. Bob, I need you back. There you go. Now take it a little bit more caudal. Let's see if that does it for us. Keep coming, sir. There we go. Now we've put, that really didn't do it. Come a little bit more REO, and let's see if that does it. Trying to put all three posts on the same plane. That's getting a little closer. That's pretty nice. Come REO more. Come REO. There you go, right there. Bill, you happy with that? Okay. Yep. So now you see our posts and our buckle, and we're going to start moving a little bit more counterclockwise with our handle. And those are coming together, and we're going to look for those to lock. Now, we do something where, as we're beginning to lock this, okay, we don't, if there's a lot of calcium, sometimes you'll get some early grinding of the device.
I think we're at 0.
I think we're at, yeah, we're pretty high
really
there, aren't we?
right now.
Bob, you want to take a look quickly?
Sure.
So in our original implant angle, we looked kind of deep. So we recaptured partially and came back, and now I think we're sitting right at the annulus, so what we might call 0 angiographically. And we could do a little test here with the contrast just to confirm our pigtail position. And at the same time, I'm going to lean forward just to kind of a little energy back.
Tiny bit of leak up there at about 12 o'clock, 12:30.
Pretty small.
That's pretty trivial right there. Not seeing a whole heck of a lot.
And you see we're locked on the one side, on the left, we're locked. The middle and the non-side still are not completely locked, but we've got a ways to go. So Bob, what do you want to do with this?
Well, I would say, first of all, that you saw that happened, that locking happened without any more unraveling of the valve. So the energy kind of caught up. The second thing is locking doesn't mean irreversibility. You can still recapture if you need to. I think with this valve, we kind of expect 0 PVL. So if we have any, I would say recapture and come a little deeper. But if we'll just use our echo to guide that answer.
So Becky, is this similar to what you do? You use echo to guide, TE to guide this?
Yeah, we do. I've gone away from using biplane imaging for color Doppler because the frame rates and line density, so temporal and spatial resolution is not as good. So if you go to just the short axis alone, throw the color on, and then just go into the LV alpha tract. So you're really just worried about the paravalvular regurgitation beneath the valve. So you want to see no prosthetic material. You just want to see the LV alpha tract and just a little retroflex from here. And so you see the red around there, so you've got PVL. And I would say this device can take that away if you maybe
the one thing I want to stress is we're having a fairly easy conversation here, just kind of back and forth to refine our position. And they're separated, and just given that time, I'm not doing anything. You see we've locked on 2 of the 3. Do you see that, Bill?
Yeah.
We've got a little bit of a barrel shape to this. There's not tons of calcium to grasp on this. So I think what we're going to want to do is do a pretty aggressive push-pull tug test. What do you think?
I think so. I think that we maybe even go to locking before we did that, because we just did, while we were talking, a little release and come back. And I think we went from 0 to maybe -2.
So I think we're not locked on the non. Do you agree?
I agree.
Okay, so I'm just going to do a little tug test there and see. We're pretty close.
Push.
And I think we're locked. Bill, you think we're locked? I think so.
Let's do a cine, dry cine.
Okay. So we're locked on all 3. I'm pretty happy with that. Bill, you happy with the way this looks in terms of the locking mechanism?
Yeah, the other impression I get, Dave, is like a mulligan. If you resheath, the next time you reposition is actually a lot easier. And I think you kind of cause some mechanical valvuloplasty, and it just actually is easier to reposition if you need to.
I think that's a great point. And that mechanical valvuloplasty issue comes in. We've done a half a dozen bicuspids. It seemed like all the bicuspids that some of our referring physicians were sitting on, we've gotten them in the last several weeks. And that mechanical valvuloplasty and repositionability really comes into play with the more complex anatomies, including and especially some of the bicuspid anatomy that we've treated. Bob Burke, what are you thinking?
So we do have, definitely have some PVL there. We can show it off here going down into the outflow tract. It's about 2 o'clock to 3 o'clock there. So you got a tiny bit left.
And a lot of times that PVL, this is nitinol, this PVL resolves, completely. But that's pretty trivial to me. Becky, what do you think?
Yeah, I mean, when you look at the vena contracta, so if you go down into the LV alpha tract, you get jet spray, so it's going to look real big. But the vena contracta, when Bob's on the vena contracta, it looks super small.
It's really great. I got Becky.
And I'm thinking maybe don't do anything.
I got 2 echo. I got Bob Burke in my right ear and Becky in my left ear. This is like I'm in echo heaven right now.
Yeah, I don't think I would.
We missed the end of what you said there. Would anybody recapture?
No, I don't. I wouldn't.
Let it go. All right.
The enemy of better is best,
Yep.
guys.
All right, so we've done our tug test. Now, if you come to my hands, and
We can debate that statement in low risk, though.
So now I'm going to go to counterclockwise to end of travel, okay, with this bluish-green knob. And now I'm at end of travel.
And when that happened fluoroscopically, you can see that a little daylight happened between those 2 markers.
So between the buckle and the post, you're going to get a hint of daylight, as Dr. Riley said. Now, The next thing is to move our collar forward, so we go to release.
So David, before you do that, at
Yeah.
this stage, you did all of that. What if we didn't like it all of a sudden?
Get a mulligan.
We can do what now? We can fully recapture, partial recapture? We have to drag it out? What can we do?
I think you have a number of options. I try not to fully recapture at this point. Bill, have you done full recaptures when you've gone to this, or just partial
Yeah.
recaptures?
No, we've done full.
Yeah.
Would you mind doing a contrast study
Sure,
just
sure.
to take a look?
Ready? Inject, please. Love the depth.
0. Yeah,
Love the depth.
gorgeous.
Okay, so now we're going to take our collar, we're going to move it forward, and we're going to the release phase. I wonder if you
Go
could...
live first.
Okay.
David, do you always leave your pigtail down?
Nope.
Nope, that's what Bob is just doing right now. Okay, so what I'm going to do is advance the collar forward. So this collar goes forward, and then I take the anatomical snuff box. Can you come right here on these dotted lines here? Come right, yeah, there you go. There you go. So there's these dotted lines here. On our collar underneath, I have dotted lines. And what I'm going to try and do is match those up. Now watch for the release pin. I don't know if you're going to be able to see
Let's
it.
get off of it right now.
Yeah, why don't you go that way a little bit? Go back to our implant angle and see if they can see the release pin. Bob, I'm going to need you back.
Yep.
There you
There,
go.
now you can see the release pin. That's great. So as I match up these dots to the dots here, I mean, it's so easy if you just color within the
Coming back,
lines.
coming
You
back.
can see the release pin is coming back,
And it's back.
coming back, coming back. And now I'm going to match up my lines. My lines are matched up. Look here, zoom in, please. So all of these lines are matched up. There's actually a pause sign on this that tells you that's when to pause. Bob, one last look, but because now we still, we haven't released it.
And sometimes I'll go to a transgastric view just to see the jet, remembering that, again, you don't want to use the jet spray as an indication of severity.
Bob,
But
Yep.
please oblige the lady.
While he's doing that, I just want to point out what Molly was saying about the curved, the preformed wire. It's just keeping our nose cone off of the ventricle there. We didn't use the wire at all.
Really has no impact on the deployment ever. So, okay, Bob, what are you thinking?
So we're still seeing that tiny bit right there, that little spray. And using the cursor, I can show you right there. That's our tiny bit of PVL right there. There's a little bit of central as well right there by the leaflets
But
as
that's
we
the
take
wire,
color off.
yeah.
And that's all wire related.
So Becky, you would rate this trivial, I'm guessing?
yeah, this would be trace. I mean, I might try to go to one other view, but this is pretty good.
Where else
and-
would you
and-
like to go to, like a
Oh,
120,
just
150?
yeah, we do that, or
We can
if
do
you
a
use-
short axis on this one. It's
I'm
a
gonna
sort of
go to
rotated
release
part.
here, Bob. Bob, I'm gonna go to release. Are you good with that?
Yes.
Okay. So
Yeah,
now
I just saw 2 little jets, but very, very small.
we'll go to end of travel on this.
Fluoroscopically come out so the probe's not in the way, please.
A little bit more.
Get that out of the way, sorry.
There we go.
Okay. So Bob, you want to release this. So we got the sheathing aids. Bob, you want to get the sheathing aids off. So if you look now, the sheathing aids are still attached. And if you look at Bob's movement, just really kind of subtle movement to release the sheathing aids, and voila. Now what we're going to do is we're going to pull that wire inside the nose cone as much as possible. And Bob, come back just, you're in perfect position, never mind.
Now we got our pigtail caught in that.
Here, let me
Still
see.
got it
In.
caught. It's in the sheathing aid. There you go.
There
There
we
you go.
Nope. All right.
There you go. You're free now. There you go.
No. So what I'm going to do now is we completely recapture the sheathing aids into the sheath in the ascending. There's no need to pull this around to the descending. Unlike other valves where the nose cone may interact, there's generally no interaction with this nose cone and the valve. Famous last words. There we go. And you don't want to oversheet this, and we're done. a drama-free TAVR
Go
with outstanding appearance from a paravalvular leak perspective, and we can just have a conversation back and forth here about, oh, deeper, or, don't go deeper. Can we just do, Bob, you want to take another look, please, for me?
Yep.
And I love, maybe one of the panelists could comment, the symmetry on top and bottom of the braid density. Even though this is a little barrel-shaped from paucity of calcium on the aortic valve complex, the braid density is very symmetric. Now, if it were asymmetric, like sometimes we see with the bicuspid, still, that doesn't affect the function. Hold this, because the leaflets are sewn in between the legs of the tuning fork. So even if the braid is a little impacted or impinged on by the calcium, it doesn't affect the valve function. And I think that's another reason we see such terrific PVL rates with this device.
And again, if anything, this looks better now.
Let's do another angio just for the audience here. Bob, come back just for a picture here right above the valve.
Yep, look beautiful on TV.
All right, ready?
Look at that. That's great. That's great.
Congratulations, David. Looks perfect.
So I
That's
love
really
the
nice.
depth. The tuning forks are sitting really at the base of the annulus on the left-hand side is perfect. The old-fashioned way, old-fashioned meaning a year-old way of making that central marker would have been in the middle of our pigtail. So I think that everything here is about exactly where we want it. We're below our coronaries, so reaccessing our coronaries should not be a problem.
Bill, in the remaining minutes, there's a question that I posed you. I listened to the great discussion you had about the frequency of use of the device in your program. Tell you what, I'm going to step over here, so if you can have the camera follow me. About the frequency of use of this device in your program. And there is no doubt in my mind that when we see complex anatomy, heavily calcified anatomy, infraannular calcium, bicuspid disease, that people are going to reach for this a lot. I also think, though, the simplicity of use is important. It's not only good in complex anatomy, it's good as a frontline device in simple anatomy. And so I think this device, we've had several new operators and implanters join our group, and I think this is going to make pretty good operators out of beginners and intermediate level operators. Is that your thoughts, Bill?
Yeah, the repositionability, the thing that I think is really the best is that you don't have to really release it unless you're absolutely satisfied that you've got a very good result. And like you said, the mulligan, if you'd miss the first time, actually the second time or even the third time gets easier as the valve actually becomes more malleable. So I think that part is good. To be fair, I think there are some potential downsides, and I'm sure they'll improve over time. The 20 French sheath is still kind of a problem.
Right, I agree.
We have these borderline small vessels, and we use the core valve often, the Devolute R rather than the Pro, because that's the smallest profile sheath for transfemoral access. And then there's a concern about interaction with the coronaries, so that, especially we start doing younger patients. 10 years from now, somebody needs to go in and do an LAD stent, then how does that valve fit? So I think those are all kind of things that have to kind of come into play, but the more experienced you are with each of the valves, I think it is like golf. I mean, you're gonna want to use a driver and an iron and a wedge for the specific time and indication. Right. But this is a really good all-purpose valve.
Well, we're so pleased with this fantastic CVI meeting to have been able to perform this case. We thank you, Bill, Molly, and Becky, and we thank our friends from Boston Scientific for giving us this opportunity. And big thanks to Manos and Paul and the whole team for inviting us to do this. It's an honor, Bill, to be able to have my mentor and someone I look up to so much to moderate this case. So thank you.
Congratulations, David.
Good job. Perfect.
Okay, on time, under budget. Thanks, everyone. Have a good afternoon.